Welcome and thank you for coming to the webinar series from the Eye and Ear Foundation called Sight and Sound Bites. This is a bi-weekly webinar series that highlights the research at the University of Pittsburgh School of Medicine in the departments of ophthalmology and otolaryngology. My name is Craig Smith. I'm the Director of Development and Community Initiatives for the Foundation. The Eye and Ear Foundation supports research to advance care for vision, hearing, balance, voice, and cancers of the head and neck of the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh. The funds we provide from Eye and Ear Foundation to support research are only made possible because of the philanthropic support we get from many of you and others. So thank you for that. A few housekeeping items for today's program. You'll notice that the chat function is disabled, so you won't be able to use that. However, we do have the Q&A function open, and so please feel free to submit questions about the program at any time during the program, and then after Dr. Stinnett's presentation, we'll go ahead and go through and answer those questions. We do ask that you refrain from asking super personal medical questions that might not be relevant to the larger audience. However, if you do want to ask those questions, please feel free to send them to myself. My email is craig@eyeandear.org, and we'd be happy to pass them along to Dr. Stinnett to answer offline. You will also be added, if you're not already, anybody who's attending today's webinar will be added to our mailing list, and that way you'll be able to keep up to date with blogs, newsletters, webinar invitations, and invitations for future events as well. So today we have a wonderful topic. It's called Bridging the Gap Between Voice and Swallow. We're joined by Dr. Sandra Stinnett, who's a doctor in our Department of Otolaryngology. Dr. Stinnett is a laryngologist specializing in the full spectrum of voice and swallowing disorders. She's particularly interested in endoscopic and office-based approaches, in addition to the use of laser treatment and laryngeal disorders. So I will turn it over to Dr. Stinnett to start today's program. Dr. Stinnett.
Thank you, Craig. Thank you, everyone, for joining us today. Again, I'm the director of the Swallow Disorder Center, and it's been such a great experience to be able to practice at such fertile ground where you can basically just have an idea and run with it with all of the support. So thank you for joining. I have no disclosures. So today we'll just talk about the anatomy and physiology of voice and swallowing. What is dysphonia and dysphagia? How do we work it up? We'll go over some cases and also some treatments. It's a pretty broad topic, so this is going to be like a 50,000-foot view of the pathophysiology that can occur in patients that have voice and swallowing disorders. So a lot of the times when we think of voice and swallowing, we don't realize how integrated they really are. And swallowing is really the passage of the bolus of food from the mouth all the way down to the stomach, and the conduit is the pharynx and the esophagus. And so while we're passing food and liquid into our food tube or esophagus, we have to basically go over the voice box mechanism to do so. And it's quite amazing when you look at it, and I'll have a few videos that display the swallowing mechanism and the voicing mechanism of how coordinated these functionalities are. And so I like to look at it as an interstate highway where things are crossing over because it is that complex but interwoven. So when we're looking at voice production, also known as phonation, it's basically the way sound passes over or air passing over the vocal folds to produce sound or produce voice. The primary function of the larynx is to protect the airway, and then the secondary function is to produce voice, and then the third is swallowing. So three important jobs that this one organ has, and personally, in my biased opinion, I think it's the most important organ, is to speak, breathe, and eat. And so I don't know if you could see my pointer, but on the right side of your screen, you can see the vocal folds are closed. So they close to speak, and then they open up down into the windpipe where they go into the lungs to breathe. Behind the vocal cords, you can see this little soft tissue over here. That's where the swallowing apparatus is. And in the front is where the throat is, where your tongue is. So there's a little caricature next to the pictures that I'm pointing at where you have the nasal passage in the oral cavity, and that green bolus of food, that's just food particulate, going down into the throat bypassing the larynx and going into the food tube. The swallowing mechanism, on the other hand, has a little bit more to it. So it's partly reflex, partly voluntary contraction. You have the oral phase where your food is prepared in the mouth, that's voluntary. And then you have the pharyngeal phase, that's more reflex, that's stimulated when food touches the back of the throat. And then you're going to get contractions. We'll talk about that in a little bit more detail. And then esophageal portion is when the food gets into the food tube and it basically is squeezed down, and that part is involuntary. So the oral phase is when you're chewing, your lips are sealed. That takes about 1 to 2 seconds. Your teeth are working. You're trying to get that steak down into a really good mushy consistency. Then for the next second, which is really fast, it's got like 5 steps. The food triggers the point in the back of the throat. That's going to trigger the closure of the nose and of the oral cavity, so that food doesn't regurgitate back through the nose. And then you have this concerted closure of the larynx where the vestibules close. And I have that picture again here just to display how that happens. So these 2 little knobs on the back are going to contract close together by the IA muscles or the interarytenoid muscles. And then you have these muscles on the sides of those knobs that are going to help that little floppy thing called the epiglottis come over and cover the voice box so that nothing goes down the wrong pipe. In addition to that, you have the soft tissues on top of those white bands that close as well and approximate to protect your airway. The vocal cords themselves, those white bands themselves actually close up. And then that Pringle looking thing, the epiglottis flaps over. So multiple mechanisms that are crucial in preventing food or liquid from going down the wrong pipe and impacting voice and getting in the airway as well. Then you have the elevation of the entire larynx comes up and out, and that opens the esophageal sphincter, which is the food tube on the back here, in order to allow food to just go down the chute or down the hatch. And then esophageal phase is everything we can't see in this slide, basically. Everything goes into that esophagus and is squeezed down via a dialysis mechanism where it squeezes the food down into the stomach. That's the longest part of the swallowing mechanism, 10 to 15 seconds. So when we're looking at voice problems, dysphonia is what we call abnormal changes in the way that a person may sound. There's a plethora of causes, but just to run through a few, sometimes patients could have abnormal voice secondary to trauma, like, vocal athletes, as I'd like to call them, coaches when they're yelling, singers sometimes if they've been performing for weeks on end. Any vocal trauma, you have kids, I have 3 kids, I have vocal trauma all the time. Any trauma to the voice box that causes an issue with the sound of the voice. Irritants and toxins such as smoking cigarettes or vaping can cause different abnormalities in the voice. Infections, laryngitis, neurologic is a big one where a lot of the voice problems that impact the larynx from a neurologic standpoint often translate to swallowing problems as well. And that includes Parkinson's, paralysis, dystonia, which is abnormal movements or inability to control movements. And then presbylarynx, which is the thinning of the vocal folds as it pertains to age-related changes, or as I like to tell my patients, wisdom-related changes. And then tumors, benign or malignant cancerous tumors, can also cause changes in the voice, especially if they are on the voice box. And they could also cause changes in swallowing due to secondary weaknesses that may be associated with them, or pain and discomfort. And so when a patient presents to us with voice problems, we are going to perform a video laryngoscopy exam. And that's just a fancy way to describe a camera that we use that uses special lighting to show us different properties of the voice box. And so you can see I'm enamored by the camera. It just allows us to see places that, most clinicians can't see. And so it's very niched and very private. And, you know, it's great to be able to help diagnose and be able to visualize that in those patients that need it the most. And so this is the positioning. Usually it's just a regular exam room where you're leaning forward. We numb you really well with spray. And we use this flexible scope to go through the nose. And it doesn't go the entire length of the scope itself. It goes maybe 5 or 6 centimeters into the nose. And then we look down at the voice box. And we are able to assess the structural integrity of the vocal folds, as well as the movement. Like I said, they open to breathe and close to speak. So we can see how that functionality is working. And then with the strobe light, we look at the vibratory patterns of the voice box, which could clue us in to whether there is a presence of a lesion or mass or scar tissue present. And then, you know, big gestalt view, we're looking at where does the saliva collect? What is the consistency of that saliva? Sometimes the pooling of the saliva can lead us to clue us into various deficits in swallowing mechanisms for that particular patient as well. And so here is a normal test of a patient for this study. So having them do various tasks, that each sniff helps us to look at the ability to open and close well. And then changing pitch modulation from low to high. It checks another part of the laryngeal function, how their ability is to change from a higher to lower pitch and stretch those vocal cords really, really well. And so this is normal function. She did a great job. Abnormal lesions and things that you may see on a video strobolaryngoscopy. This patient, you can see there's a little bit of a concavity on their vocal folds, indicative of weakness. Also, atrophy or thinning of the vocal folds. It can mean weakness as well if one of them isn't really moving very well. On the back part of that voice box, you can see some collection of secretions that may make you think that there is an issue with swallowing, either above or maybe some weaknesses in the pharyngeal muscles that are surrounding the larynx, or something below, you know, that we can't see here or on this particular exam may be blocking and not allowing food to go down efficiently. Here on the second picture, you see a little ball, a yellowish ball inside the vocal fold that looks like a cystic appearing lesion, and that can cause some voice deficits, not much swallowing, but maybe some voice. This big Goomba is a malignancy that can affect closure of the voice box. And so if they're not able to get adequate closure, in the same way with the atrophy, they may have some liquid slipping into the wrong pipe. This is a fungal infection on a patient that may be having some discomfort with swallowing as well. And that can cause some issues there, as well as some voice issues. And this is a granuloma, it's pretty big, that may cause airway obstruction, but also can cause some deficits in the inability to close and allowing some things to slip down the pipe, in addition to some voice issues. So disorders of swallowing are known as dysphagia. So it's not a diagnosis, it's just a symptom describing that the safety and efficacy of being able to eat or swallow has been impacted. So in the same way, there are various causes, a number of causes for dysphagia. Structurally, we're looking at oftentimes things that we can't see on a laryngoscopy exam. So webs in the food tube, some diverticulum, which are just pouches in the food tube that might collect food and make it difficult to swallow, and what we call Schatzki's rings, which are a little bit lower in the food tube, but sometimes you can get referred sensations like, oh, doc, it's stuck up here. So it's kind of hard to localize. So you want to have all of these things on your radar. Neurologic, again, we talked about the Parkinson's, the strokes, and the CVA for the patients that have voice issues as well. And then functional as well in the voice population, some tension. Sometimes patients may have what we call a globus sensation, or feeling like something is stuck in the throat, and some associated voice changes that could be attributed to stress, but you always want to make sure that there's nothing else going on. dementia, and also surgical can also be a result of swallowing issues. And so the interrelationship, as you can see, between voice and swallow is very intimate. And I tried to come up with a Venn diagram for it. But again, it's more complicated than that because there's so many pathways and crossing over that occurs between voice and swallow that it's not just a simple overlap as much as it is interwoven. Because essentially it's the same organ. The stomach just takes off, the esophagus just takes off and extends, is an extension of the swallowing mechanism. And so there's some controversy that voice symptoms shouldn't be used to completely diagnose or symptoms of dysphagia, but if there are certain voice findings, then it should clue us into, okay, perhaps there should be a voice issue. So hoarseness, breathing, breathiness may be indicative of a vocal cord weakness, and again, impact enclosure, and again, could result in liquids going down the wrong pipe. Vocal fatigue could make it feel like things are not going down very easily because we're squeezing super tight with the same muscles that we use for voice, we often use for swallowing. And so those could get fatigued as well, making swallowing mechanism challenging. Hypernasality, kind of talking like this, and that results in what we call velopharyngeal insufficiency. I don't know if you remember when we were talking about the swallowing mechanism itself, when the nasal passage is blocked off. But if you're hypernasal, that may mean that there's some deficit in the ability to block off the nasal passage. And as a result, food can sometimes, and liquid can regurgitate through the nasal cavity. And so if you hear somebody that has some hypernasality, sometimes that may be part of their clinical picture. Tension, as we discussed, and even wet speech, that may be indicative of things going down the wrong pipe and collecting either on the vocal folds or just below the vocal folds. Not necessarily a voice, but is related to the voice box, is weak cough can be indicative of somebody not being able to protect their airway as well. And then enunciation is also not so much voice, but if a patient is having difficulties or weakness in their tongue, not only is that going to impact the way that they pronounce words, but it's also going to impact the way that they are able to effectively chew their food and propel it back in order to begin the swallowing mechanism. So dysfunction in one area could certainly lead to issues in another area. Like I alluded to before, vocal cord paralysis, you have breathy voice, shortness of breath because you're not able to connect the vocal cords together, and you have a leaky pipe essentially of air leaking, but also sometimes liquid slipping into the airway. Hypernasality, food regurgitating through the nose. Dysarthria is what I mentioned before with tongue weakness or tongue difficulties that result in difficulty with pronunciation, but also difficulty with chewing and swallowing. Tension, difficulty with getting food down, or just fatigue in that muscle area. Also, some patients have, cancer of the oral cavity that could affect the way that they pronounce words, but it could also affect oral competence. So we're not able to suck from a straw very well, or even manage liquids and solids as well as we would if the oral lip portion was integrity wasn't compromised. So a lot of things that are interrelated and can affect. How we test for swallowing function, there's multiple ways. The two most common ways that we do it in the Swallow Disorder Center is the fiber optic endoscopic evaluation of swallow, or we call it a FEES for short. So it's the same thing that we're using to look at the voice box, a camera through the nose, and then we have the patient swallow various consistencies, all dyed blue with a natural food coloring. So we do water, several iterations of water, different quantities, and then we do applesauce, and then we do a graham cracker, just to see solids, liquids, and puree kind of diet, what that would look like. And so this is just a video showing that in a normal patient. We'll start with liquids, and it's relatively fast, like we said in the explanation of the phases of swallowing. So you might miss it, but just look for any residual blue dye, which a little bit is okay. I'll also show you. So there you see, there was some water that just literally just passed in and went down the hatch. And you can see that the vocal cords are still closed after the swallow. And then the next one is another swallow of water. Passing in, looks good. And then here, the next one is going to be some applesauce. And we just look down the windpipe to make sure there's nothing collecting below the vocal folds. So I think that was one swallow of applesauce. And then now we're going to do a graham cracker. So you could see he's chewing. You see, this is the back of the tongue on the bottom part of the screen. So while he's chewing, you can see that tongue movement, the tongue propels stuff back. There's a little bit of schmutz on the camera, but he did great. There was no residual material that you can see. So that's a normal swallow. Another way that we assess swallow function is using an X-ray in a technique that we call modified barium swallow study. And this is great because just like in clinic, when we do the fiber optic fees, you have a speech language pathologist there with you. And what we do is we assess the swallow, and then afterwards, if it's non-surgical, you have a discussion with the speech language pathologist that it then gives you strategies. And then we're able to test those strategies simultaneously while we're doing the swallow assessment. The modified barium swallow and X-ray works the same way. You have a speech language pathologist that is with you. They are diagnosing and assessing the swallow mechanism and then giving you strategies simultaneously to see. So this is a patient, you have their profile view, and you can see they're swallowing barium, different consistencies as well. The barium is radio opaque, meaning you can see it go down. So you can see in the mouth, there's that radio opaque or that dark consistency. And it went right down and not into the airway. But here's another patient. You could see it pooling in the area called the vallecula, and then it's kind of staying stagnant in the food tube and trickling down. There might be some blockage here. And he also unfortunately had some going to the airway as well. So very abnormal swallow, but very great instrumental tool to utilize. And typically, you know, if you're worried about aspiration or any weakness in the walls of the throat or the pharynx, or anything in the oral cavity, like tongue weakness, or any abnormalities in the chewing mechanism, then you would get a modified barium swallow study. The fiber optic endoscopic study that we just looked at before with the camera in the nose actually bypasses the oral cavity, so we're not really able to get a good assessment of that. And then you have a whiteout phase when that Pringle epiglottis flips over. And so you're missing like a millisecond of very important data, actually. So if there's any inclination, the modified barium swallow to follow, you can never go wrong with that. And oftentimes I do get the modified barium swallow if there's a question in clinic. And so this is a lovely lady that had vocal fold paralysis. And I just wanted you to hear the voice and see the exam. She had idiopathic, meaning of unknown cause, could have been an infectious cause, but non-surgical cause or anything that's compressing on the nerve. And so she presented to clinic and had some difficulty swallowing liquids, was doing okay with solids, but you can hear her voice is very breathy and she can't have, her vocal endurance is not that great. She doesn't have longevity with her ability to speak or project.
Good. Then pull that ah sound out again. Ah. Good. And in one short sentence, tell us why you're at the Voice Center today.
I'm talking. When I started as laryngitis a month ago.
And here's a video laryngoscopy looking at her paralysis. So you can see the cord on the left side of the screen. It's actually the right liver cord. Is working really hard trying to compensate and get closure. And if we were to look a little bit closer, you could see there's a gap there. So she's not getting really good closure of her voice box, and that's the result of the breathiness. That's also the result of her inability to get loud. And also when you're swallowing, things just slipping through and eking through.
Good.
This gentleman actually has atrophy of the vocal folds, sounds pretty similar, but instead of there being a weakness of the nerve, there's actually just a what we call muscle wasting or muscle thinning that has occurred, resulting in his voice changes.
My father makes laryngeal. Looking at the beat.
So you can hear actually, I just wanted to point out for him, the squeezing, he's squeezing very like significant amount in order to try and compensate for the deficits that he has. So he's using the false voice, false vocal cords on top of the true vocal folds because they're too thin and not getting good contact. And you could kind of hear the liquid. There's a little bit of a wet component there. That's a little gurgly as well. So you could see that there might be some saliva or something collecting on his voice box as well. Hold on, let me get over here.
Very good. Ladies and gentlemen, say E again.
So you can see the two bands trying to come together. You see the saliva kind of gurgling around the voice box as well. And a pretty significant gap. He's a funny guy. Pretty significant gap as well.
Time to sneeze each other from the lip.
And so this patient is a patient of mine that had oropharyngeal cancer, status post-radiation, then had a stroke and resulted in vocal fold paralysis. And also some tongue weakness. So you could hear her voice is a little bit breathy. She has some throat clearing as well. That could be indicative of something just irritating her in her voice box or trying to slip through. And then she also has some pronunciation because of the tongue deficits as well.
When the sunlight strikes raindrops in the air, they act as a prism from a rainbow.
And you could also hear with her, she has some hypernasality as well. This is acting good.
When the sunlight strikes raindrops in the air, they act as a prism from a rainbow. The rainbow is a division of bright light into many beautiful colors.
And then we're gonna see her swallow and what that looks like. She has significant difficulty. We're working with her a lot. I actually injected the vocal fold, and talk about that a little bit later. She's been through therapy as well and working really hard, but sometimes post-radiation, it's challenging. We'll talk about that. So you can see, out of the gate, there's a ton of secretions. It's kind of hard to see with the camera because there's secretions collecting on it. But in the back of the tongue, because of her tongue weakness, she has saliva pooling in there, probably seeping down, and that's why she has a lot of throat clearing as well. She gets decent closure at the level of the vocal fold, but sometimes coordinating that when you're constantly spilling in is challenging for these patients. So she took a good swallow. The speech language pathologist cued her to do a forceful swallow, which cleared some of it. And she just took another sip of water that's pooling there. So then we had her do some hygiene. I think we had her spit up some of that stuff to kind of get a good exam of her voice box. And then we had her trial some applesauce, and that was really challenging for her. So you could see here, the applesauce is just pooling in the back of that tongue and just slipping down. She does an okay job protecting her airway. I don't think I have that clip to where we dip down and look closely, but it was challenging for her. We had to really walk her through that portion. And so she got swallow therapy. The name of the game for that, for patients, especially with radiation, is aggressive swallow therapy, in hopes of improving swallow, but definitely to help prevent the progression of swallowing worsening, because that radiation fibrosis is constant, or can be. So management and treatment, as I was alluding to, it's a multidisciplinary approach. I couldn't do what I do without my awesome team of speech language pathologists, both on the voice and the swallow side. So you have a team that navigates voice, and sometimes there's overlap, but the swallow is also its own entity as well, with its own set of exercises to target different things, even though they are related. So the dysphonia, sometimes you could give some medications. There's some medications that we use off-label for vocal fold paralysis to help with that. Voice therapy, some surgery, so vocal fold injections for vocal fold paralysis. If it's a tumor, we take it out. If it's a big mass or a granuloma, we also remove those too. Reflux medications to optimize that as well. So there's a variety of treatment options, but I would say for the most part, therapy will most likely be involved for voice as well as for swallowing. If there is a deficit, there is some therapeutic interventions and exercises. And I tell my patients, it's just like abs. You know, you have to keep at it or else you're not going to get those abs, right? So it's not a one and done type of thing. Same with voice therapy. You got to continue implementing the strategies so that your swallowing and your voice stay up to par. We also give diet modification recommendations. So example, for our lady with the cancer, there were some diet modifications that were needed to be made so that we don't risk patients getting aspiration pneumonia, which can be life-threatening. And also surgery as well. You know, it's like plumbing. If it's blocked up, we open up the pipe. If there's a sac, we cut it out. And so depending upon the entity and the etiology, there's treatment modalities for that. And so these are just a few of the tricks that we have in our bag for treating swallowing / voice. The tube that she's exhaling into is called the EMST. So it's expiratory muscle strength training mechanism. And so it helps patients that, for example, may have Parkinson's, and it's found to be helpful in head and neck cancer patients. And it's also found to be effective for patients with certain voice issues as well, to strengthen the muscles that are involved with cough and breathing. And so, you know, it helps to protect the airway and protecting things from going down the wrong pipe. On the tongometer, which is fairly new, there's another one that's similar to it that's called the IOPE. And it's basically helps with tongue strengthening mechanisms. The novelty in this is that it comes with an app so you can record your progress. And sometimes that feedback is kind of helpful, especially you feel like you're not doing it in vain. You could see your progression and your improvement. It works well for patients that do have tongue deficits. So this is a neat little tool. We also have chin tuck against resistance balls that kind of help with pharyngeal strengthening if that's a deficit that we need to target as well. On the surgical side, balloon dilation is something that we do regularly, and I do them awake in clinic, so that, you know, oftentimes these patients need repeat procedures. And so offering them the ability to not have to undergo general anesthesia, just walk in, get it done, walk home, has been a wonderful ability to be able to offer that. The same for vocal fold paralysis. A lot of our patients that have either atrophy or vocal fold paralysis, we can do awake injections. In our Parkinson's patients, if they have a significant amount of thinning of the vocal fold, then we can trial an injection to see if that helps not only with the voice, but also if it helps with the swallowing and choking on the liquids, if that is something that they deal with. And then for the patients that have nasal regurgitation of their food content secondary to hypernasality, we can perform an injection pharyngoplasty where we inject the back wall of the throat so that the palate gets in contact with that area and you get better closure and prevention of food regurgitating into the nasal cavity. So this is just a video displaying a vocal cord injection. And so we numb you really well with aerosolizing the lidocaine, or we just topicalize you with some lidocaine numbing medicine. And we put the camera through the nose. It takes two pairs of hands, camera through the nose, and then through the mouth or through the neck, we're able to plump up that vocal fold. So you can see it's getting plump in order to help facilitate adequate closure and protect the airway from things passing into it, and also providing adequate voice as well. The luxury of doing it awake is, number one, it's instant. So you can hear the progress and the improvement in the voice. Swallowing, you have to wait a couple of hours because you're numb, so we don't want you to aspirate, but after 2 hours, you can take it for a test drive. And then we can push the envelope while we're watching your airway and visualizing the airway so that we can ensure that we are getting the best possible outcome while you're awake without compromising breathing, because we can see your airway. So that's one of the reasons why I like doing the procedures awake, and immediate gratification as well. This is the injection of the palate. So these are the exercises that we have patients say while we're in the nasal cavity looking at the soft palate. And usually this is somebody that was pretending for me, but you would see bubbles when they did those exercises, the shushes and the dana-danas. And so we go through either through the nose or through the mouth and then inject the back wall so that you get better contact to improve the competency of the velopharynx. And then this is this is a transnasal esophagoscopy. So this is a dilation that we do to basically open up any blockages in the food tube. So camera through the nose again. We look all the way down into the food tube. This time it's a longer camera than the video laryngoscopy. And then once we're in the food tube, we put a wire into the camera through the food tube. And then we put a balloon over that wire. And you can see that balloon right there, the blue cord. And that balloon is right into the entrance of the food tube. And the patient's awake, they're sitting right there. And we inflate the balloon, and that stretches out and stretches open the entrance into the food tube. And then you want to make sure that, you know, it pushes onto the voice box. So it may feel like things are narrowing, but you can see here the airway is patent. It's just a sensation of that balloon just spreading things a little bit. And patients usually tolerate it really well. And again, the same thing, you can go home and test drive it, and you know immediately if it has worked or not. So that's it. Thank you. Any questions?
Thank you very much, Dr. Stinnett. That was a great presentation, and we actually do have a lot of questions. So we're going to dive right into those.
Okay.
The first question is, can vocal cord tumors be HPV-related tumors?
That's a good question. Yes, they can be. There's some research to kind of look into it as far as, you know, the mechanism of patients that get the HPV-related laryngeal tumors. I think we're still trying to figure that out. It's not as parsed out as the oropharyngeal tumors, the tumors in the throat. But I have seen patients, and this is anecdotal, that have HPV-related laryngeal cancer that have never smoked. Again, this is super rare. You know, I could count maybe 1 or 2 patients that I can recall that have had that. But I don't think the data is certain about why or how that happens in the larynx. I do know it's like transition zones. So just like, you know, you have transition zones in the tonsils, and then for cervical HPV, it's a transition zone, meaning it moves from one cell type to another. The lining of the larynx also has a transition zone. And so it makes sense that there would be HPV related tumors in there as it pertains to cancer. The other HPV related disease that can happen in the larynx that we kind of know more about is recurrent respiratory papillomatosis. And those are usually involve strains of HPV that are non-cancerous, though there are some strains that can transform to cancer, which are also rare. And again, it's the transition zone. So the papilloma it's just like clusters of tissue that just sit on the voice box. Most patients present with hoarseness with that when it gets really, really bad, but it would have to be bad for a little while. They would get airway issues. And so we have to take those patients back periodically and remove the papilloma from there. There's two different types. I'm going to not take too long on this because I could go long about it. There's a juvenile type that you're born with, and that is considered to be transmitted from the mom to the baby. And then there's a type that you get when you're older, which we suspect could maybe be a dormant version, or, is it sexually transmitted? There's a lot of uncertainty about it still, but the treatment is still the same. It's surgical removal. And there's vaccines that are coming down the pike for it, but there's also the HPV vaccine has found to be pretty good with treating, not completely abolishing, but I think reducing the rate of growth for those things on the voice box.
Next question is, can you discuss how dementia changes swallowing patterns?
Very good. So that's multifactorial. The cognition component of swallowing is so important. And so if the patient is not very aware or lucid, that could be a big contributing factor to aspiration risk, as well as just senility. I don't like that word because it sounds kind of mean, but just natural aging processes of muscles getting weak, things getting atrophied, and things just becoming more discoordinated. Oftentimes it's hard to treat patients with dementia because they have dementia. So you want to make sure that there's nothing else significant going on that we can treat, from a medical surgical standpoint. But the therapy component gets a little challenging because you want to be able to strengthen those muscles and provide strategies. And a lot of our patients that suffer from dementia aren't going to remember to do a cough after they swallow. And so it gets challenging. A lot of the time, I remember one patient in particular, as a caregiver, you're working, even if you're working from home, it's hard to kind of navigate that and remind the loved one to implement the strategies while they're eating. But oftentimes that's what it takes. It's eating under supervision, kind of assisting with the strategies provided. And unfortunately, some of these patients may require, feeding tube at some point. But yeah, it's challenging with dementia patients, and we try as best as we can, to give them the support that they need.
Does overall health play into the susceptibility for any of these conditions, such as weight, smoking, pollution exposure, etc.?
That's a loaded question. Does overall health play a role in these conditions? Yeah. So it certainly does. It will probably gear you towards one cause versus another. If you're having laryngeal cancer, we know that smoking is a significant risk for that. Diet modifications and things like, overweight can certainly impact voice from I would say a respiratory support standpoint. But it's not that simple where you could be like, okay, I'm going to cut out smoking and then my swallowing is going to get better, because, depending upon what the underlying etiology is, you want to be mindful of that. Sometimes it's genetic or familial. Like if you have Parkinsonian or some neurologic moving disorder or ALS, those things are things that do impact the larynx. And unfortunately, it depends upon your family history for those particular things. So I would just say, be as mindful as possible of symptoms. If there's voice changes, normally we say if there's any dysphonia or changes in your voice that last more than a month, then get checked by a laryngologist or an ENT, especially if you're a smoker or you do have any high risk behaviors, and advocate for that, because sometimes it's hard to get to us. But if you insist or just call us directly, we could help facilitate that too. But yeah, that would be the short answer of it. That's a very good but complicated question.
Does repeated strep throat cause damage to swallowing and the larynx?
Good question. I would say repeated strep throat wouldn't cause damage to the larynx. Repeated strep throat can cause the tonsils are higher, so they're in the back of the throat there. They're higher than here. And so the larynx is a little bit lower. They can cause, issues to the pharynx. So that's why when you have strep throat, your entire throat may feel like it hurts, but it's really localized to this area. And so you could get, soreness, pain and discomfort that could impact your swallowing and even your voice, because all of the things that are here, including the tonsils, are important in what we call resonators. They're called resonators. And so anything that affects the ability of the muscles, they're called the constrictor muscles in that area, to function the way that they normally do, are going to impact voice and swallowing. As far as long-term effects, not immediate, not anything that is common that can cause it. Now, surgically, after surgery, you remove the tonsils, and that's great. But I was just talking about this with one of my colleagues, particularly for singers. Removing those tonsils could cause some changes in the resonance of the voice. So some people do singers' tonsillectomies in order to facilitate that as well. But yeah, those are the main immediate effects, not anything that's significant or long-term from a voice or swallow standpoint other than that.
Is this type of treatment and surgery typically only available in cities and larger healthcare settings, or is it also available in more rural areas?
Good question. I would say easily to say yes, it's more available in cities. I probably had a hard time getting patients to have awake procedures in more rural settings. They can be done under general anesthesia, and so you might have an easier time finding somebody doing procedures like injections and dilations under general anesthesia, which is fine if that's all you have access to. It's effective. Speech pathology and interventions from a speech therapy standpoint, usually I would say is more accessible at an academic center, just because they're so niched and nuanced. Like I said, we have a group of people that do voice, and all they do is voice. They love voice. They eat, breathe, and sleep voice. And then we have people that do swallowing. And so they're really good at what they do. And so that might be a little bit challenging. But from that standpoint, with one good thing that came out of COVID is virtual visits. So if you ever needed therapy and you got evaluated by a specialist and they recommended therapy, then as long as, I believe you have to be, the therapist has to be licensed in the state that you're in. So if they're licensed in Pennsylvania and only in Pennsylvania, and you're in Johnstown or something like that, as long as you're in Johnstown, then they could see you. If they have a license in California and you're in California and they're in Pennsylvania, that's fine. But if they don't have a license anywhere else, they can only do a licensed virtual visit in the state that they are in and practicing in. So that's a good option for those patients as well.
What percentage of the population have voice and or swallowing issues?
Wow. I don't know. I would say that know it. It's a large number, and the problem is perception, right? So there's literature to show that women are more likely to be seen for voice issues more than men. And And so I suspect that there's a large population of folks that are walking around and ignoring it because it's not like it's a heart attack, you know. However, it should be treated as important because number one, it's your instrument, right? So you want to be able to communicate. It's a disability when you can't. And so like, you know, teachers oftentimes unfortunately don't make it to us in a timely fashion, and then they have a lesion and we got to go to surgery and things like that. And so I would say a large number of us do have voice issues and probably ignore it until it gets really bad. From a swallow standpoint, you know, I think that's more relevant and pertinent because patients want to eat. It's part of our culture. It's what we do. We just eat together. And so, you know, we do see a significant amount of patients that do have swallow issues related to reflux, related to masses, you know, so both are related to neurologic issues. So, you know, I think it's tough to quantify it. But I would say more people are walking around with voice issues that are not examined compared to swallowing issues, just because swallowing is just more palpable and people want to get that fixed.
What is the typical recovery time from surgery, and how long does it take to notice or feel the changes?
Good question. So the ones that I showed today, the recovery time is little to none because there's no general anesthesia. You know, the injection works immediately for the, and the dilation works immediately. So the voice procedures, because it's voice rest for 2 days, that's pretty much it. And nothing to eat or drink for a couple of hours after the procedure. After 2 days, you can talk, and we test it in the procedure suite while we're doing it so that we know that we've done the appropriate amount and we've reached a satisfactory voice for both you as the patient and myself as a clinician. And so I would say 2 days just because you have to be on voice rest. For swallowing, like the stretching of the esophagus that we do, if it's done awake, again, 2 hours, because you just can't eat or drink for 2 hours. And then when you can, you just check it out. I tend to believe that doing the stretch awake fares better because you don't have significant amount of soreness. When we do it under general anesthesia, the instruments are not flexible. And so they can cause some discomfort in the throat after the surgery. And so, you know, that when you're going under general anesthesia, just because of general anesthesia alone, I would say at least a week of no heavy lifting at least. You may be able to get back to your leisure activities light within a few days, but nothing, don't go lifting weights 7 days after that under general anesthesia.
So kind of a similar question here. If somebody starts using speech therapy to help with their voice and swallowing issues, what's the average length of time that this therapy is needed before seeing a difference?
Everybody's different. So we typically do first, and swallowing and voice are different. So with voice, you know, the strategies are implemented. We just do a couple of sessions, and if there isn't a response to treatment, then all our multidisciplinary team reconvenes and we try and figure out another plan. And so if it does work though, on average, depending, I would say upon the circumstances, we can do upwards of 4 sessions and they're spaced out. So it's like 1 session every other week. And then you have to do your homework. You have to go home and implement those strategies, come back, and then they build upon the strategies every week. So that's the voice end of things. For the swallowing end of things, it's a little bit more challenging because again, it's not like it's going to be a switch, right? We're working with muscle weaknesses and deficits. And the strategies, for example, if they say the left vocal fold is not working, so they may give you a head turn to the left, chin tuck and swallow. Those are strategies that if it works immediately. But from a strengthening standpoint, it's like abs, you know, which I'm still working on myself, but you just got to keep at it. And that's why I like the tongometer, because you see the difference, even though you're like, I'm not eating a steak yet. Why isn't this working? but you'll see the difference, and then it'll also help us to gauge, okay, can we progress the diet a little bit more, let's get a swallow study and reassess since there is an improvement objectively from the exercises that you're doing. So for swallow therapy, I think they do around the same, like 3 or 4 sessions. Some are longer, like our head and neck cancer patients that have radiation, we're doing manipulations and things like that to kind of break up some of that scar tissue. And it may be like, okay, we've done our 4 sessions for the year, keep at it. Let's come back and do a session next year or reassess next year, or we may need to do a refresher or something like that. So the therapy for dysphagia for swallowing may be a little bit longer. For our Parkinson's patients, they too need a constant touch point and then a possible refresher for therapy from a voice standpoint as well as a swallow standpoint, because it's the same thing with them. It's a use it or lose it. And so we're just trying to maintain some modicum of airway protection and also quality of life from a voice standpoint so that they can be a relatively normal functioning member of society. So it's clusters of 3 or 4 sessions with touch points, throughout the year to see where we need to go.
Are there any mechanical devices that assist with swallowing similar to what they used for sleep apnea?
Question. There's one that I'm thinking of that I believe it's been FDA approved for acute use in the acute stroke setting. And it's showed some promising results where it stimulates the muscles. So it's like a tube. I think they put it through the nose and then it goes into the throat. And it kind of helps with the squeeze of those muscles and strengthening them or triggering them. And they've had really good outcomes. I forgot what it's called though. But it's so specific. That's the only indication for it. Other than that, there's like the TENS units, which haven't showed, and again, those are external units that kind of cause strengthening of the muscles in theory, but I don't think the results for that have been very good. And then that's basically it. So for sleep, I do a lot of sleep apnea research with Dr. Kappenberger, Dr. Susan in our department, and we're trying to see if there is any interplay between tongue strengthening exercises and swallowing and sleep apnea. So to that point, I don't know if we're going to get a hypoglossal, like a inspired situation going on, though there might be something like that coming down the pike. But basically to answer your question, there's interplay between those two. So you're right thinking that, but as far as I know, there's nothing specific like an Inspire for swallowing for tongue weaknesses, but the exercises have been proven to be very effective.
So for the last question here, we'll let you take a minute and look towards the future. This question is, what are some of the goals for research to improve swallowing?
Very good. So the goals that I think are going to be amazing. Our Belovsky at UCSF is working on stem cell research to kind of create stem cell implants, particularly for patients who have tongue-based weakness. I think he's starting with the tongue, but I'm sure it's going to go, even further than that, to see if we could regenerate some of the cells that have been impacted, some of the muscle cells that have been impacted to improve swallowing function in that way. So I think we're just basically scratching the surface with that. Other things are direct nerve, if we can figure out a way to help the nerve function in some capacity. I know we've tried some medications for the nerve for voice. Curious to see if that medication will be as effective in patients with swallowing deficits that may have a nerve function as well, a nerve etiology as well. And so that, and then, I think they might be looking to expand the indication for that acute stroke one that stimulates for swallowing. I've been pushing them to, because I have a lot of patients that, at some point you got to realize to them, it's like, what do I have to lose? I just want to try something to be able to swallow, because it's such a impact on the quality of life. And so I'm curious and cautiously optimistic that that indication may one day be expanded if it shows promising results. But I don't know if they've even started looking at it yet. So those are some of the things that we're interested in. And then the interplay between sleep and swallowing, though the mechanisms are counter, they are opposite of each other, because we want to strengthen the muscles in a different way than we do for sleep in dysphagia comparison. But I feel like the way that they're thinking with their models and technology, that some of that could translate. And I've been talking to Dr. Kent about some cool studies, for a stimulation standpoint as well. But yeah, it's great. It's rewarding when you can fix swallowing. It's a very rewarding experience, because it's challenging for patients and quality of life standpoint. So.
Well, Dr. Stinnett, we want to thank you again for a wonderful presentation, and we want to thank all of our audience members for joining us today on your lunch break. Please join us again in 2 weeks. We'll have another presentation coming up with Dr. Melissa McGovern and Dr. Peter Santamaria, where they'll be talking about restoring hearing and regenerating hair cells. So with that, we'll let you back to your day, and thank you again for everybody joining us.